Lovely. Welcome everyone to the Better Outcomes webinar. I am Dr. Rahul Khanna. I'm a trauma psychiatrist with Phoenix, Australia, who I'll introduce in a moment, and I co-lead Transforming Trauma Victoria, the world's first jurisdiction-wide trauma service that we're in the process of establishing. It's my pleasure to welcome you all today and also to acknowledge the traditional owners on the land on whose lands we meet today. I and along with the rest of the Phoenix team at the moment is on Wurundjeri land of the Kulin Nation, and I'd like to acknowledge their elders, past, present, and emerging, and also recognize the impact of intergenerational trauma for that community over time, and those with a lived experience of trauma who might be joining us today or who have been working alongside us. We are indeed Phoenix, Australia, a nonprofit affiliated with the University of Melbourne, dedicated to understanding trauma and renewing lives. We conduct research, we put that knowledge into action in supporting improved treatment options and greater support for trauma-impacted individuals, families, and communities. And it is our pleasure today to welcome you to this webinar in partnership with Latrobe Health Services. Click forward, Greg, who have been working with us to establish a regional Victoria trauma psychiatry clinic, and a series of these webinars and other content that we will be putting out shortly. Today, I will introduce some of those key speakers and contributors, and then Greg will take us through the webinar content. We roll next up. So please do make use of the Q&A function during the chat during the webinar, and I'll be contributing to some of those responses as we go, and at the very end I'll loop back to answer some of those questions alongside Greg towards the end. We will be recording the webinar, and we'll circulate the recording to you guys after this after the event in the coming days. And without further ado, I would like to introduce Ian Whitehead. Ian is an experienced CEO with expertise in business strategy, change management, finance, and marketing. He's worked in financial services, health and life insurance, property, retail, and distribution and technology sectors, and joined and continues as the CEO of Latrobe Health Services. It's my pleasure now to hand over to Ian to talk you through Latrobe, and thanks again for your partnership.
Many thanks, Rahul, and everyone. It's a pleasure to be here this evening. Firstly, on the next slide, just wanted to touch briefly on Latrobe Health Services. Each time I see this photo, I do reflect on our heritage and history, and starting back in 1950 and our origins in regional communities and supporting regional communities. That's significantly changed over the last 70 years. And I suppose on the next slide, just a bit of an outline on some of the key facts about our organisation today. Over 100,000 insured Australians, 40% based in regional and rural communities. I think one of the things that does hold true from our origins and our roots is focusing on improving health outcomes, particularly in rural and regional communities. And I think part of the reason we're here today, and we're incredibly proud of this partnership, is for that reason. We built and own a hospital, a private hospital in Gippsland. And as I mentioned before, we were established in 1950. The partnership with Phoenix was established back in 2022, and we're particularly proud of the service, and particularly it providing access to rural and regional Australians. And this conversation today is a good example of that service. But it's one of a range of services that we are involved in. And as a non-for-profit health insurer, I think it's important that we give back to the communities we operate in, and sort of make those communities better places. So on this slide, we've just got a range of activities and organisations we've been working with. But I'd really like just to quickly call out two in that journey. The first is Maryvale Private Hospital, Gippsland's only private acute surgical and medical hospital. We were established in not only the foundation of the hospital and the running of it for over 30 years now, but recently invested over $16 million into a regional private hospital. And the importance of that is to provide access to Gippsland and further east for a range of services. That investment saw 19 new beds, new surgical theatres, new sterilisation facilities, and new equipment into the region. I think one of the things we're incredibly proud of is over 95% of the work that was done on the hospital was actually done by local trades and local employees. I think importantly, the hospital also, by having a new modern facility, sees the creation and attraction of new specialists into the area. And more recently, we've just launched a cardiac service, which the region was in desperate need of. The next activity that I just wanted to touch on is the relationship that we've been working on, free health checks in the community that evolved into the Shane Warne, the work with Shane Warne Legacy. It started with 500 health checks in the Gippsland region, and we observed high concerns for cardiovascular disease. Probably 60% of the people who took the tests had at least one or two markers to suggest cardiovascular disease. Of that, almost half had at least two. We played an active role in working with them to get meetings with their GPs. And there was one individual, a 38-year-old male in Sale, who went with his mother to take her in Sale to go to have a test. The mother asked him, "Why don't you do a test, darling?" He did it. We put him in an ambulance and he had a triple bypass the next day. I think the thing that we're incredibly proud of is these interventions can make a real difference in the communities, and we'll continue to do that. We've done 160,000 free heart health checks this year, and certainly looking to continue that again in 2024-25. And I think that's a nice segue to this partnership. This partnership is providing access to services for rural and regional members. It is an absolute pleasure to be here, and I will now hand over to Nicole to talk through today's agenda. Thank you again for having us.
Thanks, Ian. Real pleasure. What a great body of work. And welcome, Nicole, Professor Nicole Sadler, Director CEO of Phoenix Australia, just to comment on the partnership.
Thank you, Rahul. And thank you to Ian. Look, it really is a privilege and a pleasure to be involved in this program and to have this partnership with Latrobe Health Service. Rahul outlined our mission at Phoenix Australia a bit earlier, and being involved in programs which help to improve the lives of those impacted by trauma is just central to everything that we do. And that's exactly what we've been able to do through this partnership. We know many don't get the treatment they need, or they don't stay in treatment long enough to get the impacts that they need. And this is particularly difficult the further you get away from metro regions. So being able to try different things which get improvements is incredibly important. And it's always important to be able to see outcomes in both the qualitative and the quantitative measures, because we need to know it's not just good enough to provide treatments or interventions. It's also really important to look at the outcomes and whether or not they actually are making a difference. So just really briefly, we can see here that we have been able to get some really nice outcomes here. We've had lots of very good feedback, and this quote, I think, is a really nice, just one example of the type of feedback we have been getting, and just how important it is that someone feels safe and understood by the clinician, and that you can start to break down those stigmas and barriers about seeking care. That's when you start to see changes for people. And of course, this whole idea that over that period of time, we can see 284 people. And when they came in, they were largely seriously unwell, that they met the diagnostic threshold for post-traumatic stress disorder. So they were being significantly impacted by this, and that over that time, they were able to show some significant improvements in a couple of really important parts of their lives, which mean that they can get on with things. It's about functioning and quality of life. So that 88% improving, reporting that they had improved functioning, and then that 83% agreed or strongly agreed that they could better self-manage their mental health due to the clinic. So well done to everyone who's been involved in this clinic. We always are striving to do better, to look at things, at programs and partnerships which help us to help people and their families and clinicians who are doing this important work. So thank you to Ian and Latrobe. It's been a great partnership, and have really appreciated the opportunity to be involved. Thanks, Rahul.
It's Nicole, and without further ado, I'd like to introduce Dr. Greg Roebuck, who will take us through the bulk of the content. He's an experienced trauma psychiatrist and the Lavender Baron. He is, and also the PowerPoint Baron, it seems. He'll take us through this topic of a practical management to trauma-related mental illness. He's also the lead investigator on the STOP trial, the Salexin, which is a lavender extract for post-traumatic stress disorder. It's the world's first randomized clinical trial with that agent for PTSD, and we're excited to see the results. We'll be starting to recruit for that study next month, so keep an eye out. Greg, take it away.
Thanks, Rahul, Nicole, and Ian, and sorry for the very ham-fisted attempts to manage the PowerPoints there. So today I will be talking about trauma-related mental illness, and we'll be covering how to assess someone that you think may have a trauma-related mental illness, and talking about treatment as well. I've never presented these slides before, so I have no idea how long they'll take. So we'll just get through as much of it as we do. The slides are quite detail heavy, so I won't be kind of going through everything that's on them. And my thinking was that if there is something that's of interest to you, you can watch the recording and pause it and look at that specific point. And as Rahul mentioned, I'm a psychiatrist in Melbourne at Phoenix, Australia. So let's dive in. So the word trauma is bandied around a lot these days. And it kind of has a meaning in common parlance, but it also has a technical meaning in psychiatry and mental health that it's important for clinicians to be aware of. So it derives from an ancient Greek word that meant physical wound. It was first used to refer to psychological trauma in the English language by the American psychologist William James in an 1894 paper. And in the common vernacular, trauma can refer to both a psychological injury that someone suffers, but also the event that causes that injury. For the latter meaning, we now in the research literature use the term potentially traumatic event, or PTE. So what is a PTE? So a PTE is an event in which someone is exposed to actual or threatened death, serious physical injury, or sexual violence. And there's different ways of being exposed to something. So an event can happen to you. You can be assaulted yourself, or you can witness an event. So you might witness somebody's death or somebody being assaulted, or you can learn about that event afterwards. So you might be, for instance, a police officer, watching video footage of a crime that was committed and thus learn about that traumatic event after it's actually happened. So there are lots of broad categories of events that can be traumatic or can meet those criteria. So PTEs are very common in war. Torture is a type of PTE. Armed robbery, sexual assault, kidnapping, terrorist attacks, natural disasters, serious car or workplace accidents, and sudden, unexpected, and catastrophic medical events are all examples of events that can involve PTEs. And when we look at our diagnostic criteria for post-traumatic stress disorder, the first criterion is essentially exposure to a PTE. So as you can see, I've copied out the full criterion there, and we often call it criterion. Well, it is criterion A of the criteria. So you'll often hear clinicians refer to a criterion A trauma, which means the same thing as a potentially traumatic event. And really, if you're thinking that someone may have a trauma-related mental illness, one of the very first questions you have to answer is whether or not they've experienced an event that meets these criteria. You know, if someone tells you that they have PTSD due to bullying, unless that bullying has involved, you know, a threat to their life or a threat of serious injury or threat of sexual violence, they may not have actually experienced a PT, and they may not therefore have PTSD. They might have another condition like adjustment disorder, for instance, which is where you experience a stressful event and then have mental health symptoms afterwards relating to it. So I've got, as a visual guide, some images here, you know, illustrating different types of potentially traumatic events. The other thing to talk about when we're talking about PTEs is that a distinction is often drawn between two different types of traumatic events. And this distinction was really first proposed by an American psychiatrist called Judith Herman in the late 80s and early 90s. And the two types of trauma are simple trauma and complex trauma. So simple trauma is classically a one-off or isolated event. It comes on abruptly or suddenly, it's unexpected. There's a high level of acute threat associated with it. So an example might be a one-off, you know, armed robbery that somebody is the victim of, where they've been otherwise, you know, functioning at a high level and not exposed to any trauma and going about their life, and then suddenly they're the victim of an armed robbery. That's an example of a simple trauma. Complex trauma is trauma where the traumatic event is repeated or protracted, and where the perpetrator has some degree of power over the victim, or alternatively where escape from the trauma is difficult. So examples of complex trauma include repeated childhood sexual or physical abuse, prolonged domestic violence, torture, and forced prostitution. Complex trauma has an association with complex PTSD. And that's a topic that I actually cover in detail in a video, which I understand will be released with this webinar. So we're not going to talk a huge amount about complex PTSD today, but if you're interested in learning more about it, have a look at that video. So how common are PTEs? Well, 3/4 of Australians will experience at least one PTE during their lifetimes. You can see some of the more common PTEs there. So witnessing or being exposed to the death of somebody close to you, seeing a dead body or serious injury, and being involved in a life-threatening car accident. Some populations are exposed to PTEs routinely through their work, and those populations include you know, police officers, emergency services workers. So for instance, if you're a highway patrolman, working in the police force, you will routinely be called out to, you know, fatal accidents, you know, on a day-to-day basis, and you'll be, you know, retrieving dead bodies and exposed to all sorts of gruesome scenes. So some people are exposed to, you know, hundreds, you know, perhaps thousands of PTEs across the course of their life. They have a very heavy trauma burden. So there are lots of different ways that people can respond to a potentially traumatic event. The most common response is a resilient response, a response, you know, involving alternatively what can be called resistance. And that's where someone doesn't experience any major mental health difficulties after a PTE. Another response is one where the person experiences mild, transient, and self-resolving difficulties. And those difficulties can include things like flashbacks of the PTE, nightmares, anxious or depressed mood, sleep problems, reduced appetite, feelings of anger or guilt or shame. And people who have a natural recovery response will experience these symptoms initially, and then without the need for any formal mental health intervention, those symptoms will resolve. Another possible trajectory of response is one where there are persistent difficulties. And that includes both new onset, you know, psychiatric disorders, you know, in someone who didn't suffer from those disorders before the trauma, and then the traumatic event happens and they develop a new disorder. But trauma can also reactivate or worsen existing disorders. So someone might have a past history of depression and that is reactivated or worsens following a traumatic event. So we can see visually here some of these different trajectories. And you can see there the delayed onset trajectory, and that's really where symptoms first develop 6 or more months after the traumatic event. That's not uncommon for someone to have a delayed onset to their PTSD symptoms. This natural recovery trajectory becomes a lot less common after 6 months. So we can see here on this slide, you've got a graph of, on the vertical axis, the proportion of people with PTSD symptoms, following their trauma. And then the horizontal axis shows the time point. And you can see that, and the different lines represent different trauma categories. But you can see that over the first 6 months, there is a significant chunk of people whose symptoms will get better without any intervention. However, as you can see from the graph there, that becomes a lot less likely after the 6-month mark. So, we intentionally titled this webinar, trauma-related mental illness, rather than narrowly focusing on PTSD, because I think feedback that Phoenix had received in the past is that clinicians wanted education about the whole panoply of trauma-related mental illness. So let's talk about that. So what psychiatric disorders occur after trauma? So there's a great study by Richard Bryant, published in 2010, which found that after major physical trauma, at the 1-year mark, nearly a third of people met criteria for a psychiatric disorder. Of all disorders, the most common was depression. So actually, probably the most common post-traumatic, mental illness is major depressive disorder. Anxiety disorders are really common, and you can see the rates of those there. GAD, very common, 11%. Substance abuse, which goes hand in hand with depressive and anxiety disorders, of course, was common as well. PTSD was actually less common than depression and anxiety disorders, although still pretty common at nearly 10%. And then you can see that obsessive compulsive disorder was also pretty common at 3.5%. And certainly I've seen loads of patients who have presented with a flare in their OCD symptoms or with the onset of OCD following a traumatic event, presumably because stress, worsens OCD symptoms or makes people more vulnerable to those symptoms. So although PTSD isn't the most common trauma-related mental illness or post-traumatic mental illness, it's really, really important to identify PTSD in trauma survivors. And that's because PTSD can be a really horrible illness. So what the sort of 4.5 decades of PTSD research that we have tell us is that if PTSD symptoms persist for 6 months or longer and someone doesn't get treatment, then that PTSD is likely to follow a chronic course. So it's not likely to go away quickly, and it causes high levels of disability across all areas of functioning. And indeed, costs the healthcare system more per patient than depression. So PTSD is a chronic debilitating illness, and that's why, and it's kind of really important to identify it in people after traumatic events. So what is PTSD then? What are its clinical features? So we've already talked about the need for someone to have been exposed to a PTE. So the second criterion is people need to have what we call re-experiencing symptoms. So they include unwanted distressing memories of the traumatic event, and they can occur unprompted. Someone might be lying down at night, unwinding, ready to sleep, and then what pops into their mind, but a horrible image of, something that happened causes them anxiety. Some people get flashbacks, so vivid, visual images of the traumatic event. Those can be so intense that it can feel like the event is occurring again. Sometimes other sensory modalities will be involved. They'll be like, it felt to me like I was back there. People can have nightmares that either replay the traumatic event or relate to it in some way. And the final type of re-experiencing symptom is distress or physiological arousal in response to reminders of the trauma. So, for instance, if someone was mugged by a person wearing a hoodie and carrying a knife, somebody might, might not, get distressing memories of that event. But when they see someone wearing a hoodie, they might suddenly, their heart might start racing, they might get anxious, or they, if they see a knife, in their kitchen or something, they might again, have an anxiety response to that. So, in addition to re-experiencing the trauma in some way, we also need the person to avoid the trauma, to have an avoidant response to it. And there's two types of avoidance, and either is sufficient for the diagnosis. So they need to either avoid thoughts and memories of the trauma. So when those thoughts and memories arise, they push them away. And commonly those thoughts and memories will be associated with a lot of anxiety and emotional pain for them. And that will underlie the avoidance. So they'll say, I can't think about that. It's too awful. So they'll push it away, distract themselves, try and think about something else. The other type of avoidance is behavioral avoidance. That's where you avoid, things out there in the world, and that can include specific triggers. So in our mugging example, somebody might stop chopping, vegetables at night, or they might, stop going to areas where they're worried they might see people in hoodies or see people who look like the perpetrator. But in the end, a lot of people with PTSD end up avoiding just anything that flares their anxiety. So, for instance, they might avoid going to busy public places, restaurants, shopping centres, supermarkets, and there can be a kind of progressive social withdrawal and isolation that occurs. We need to have some negative changes in their mood and their cognitions or thoughts. And so that includes, not really remembering a traumatic event very well, which is probably because they're avoiding their memories of it. Every time the memory comes up, they push it away. So they're not really kind of mulling it over, sifting through it, sorting through their memories. A lot of people with PTSD have distorted, inaccurate, and unhelpful beliefs about themselves or others or the world. So they might think that they are bad or unworthy or incapable of dealing with things. They might have difficulties trusting other people. They might view the outside world as very dangerous, and some of those beliefs can also drive their avoidant behaviors and their isolation. They can have anger and blame directed at themselves or others. They can think, I should have, prevented, my comrade from stepping on that IED, or they can think, it was my fault that I was assaulted. I shouldn't have been out, at night. Or, they can have a range of negative emotions, unsurprisingly, given their other symptoms, including all of those there, listed there. They often, derive less pleasure from activities they used to enjoy and withdraw from those activities. They can often feel very detached from other people, and I think in part that tends to happen because if your body and your mind are not a very pleasant place to be, one way of coping with that is by kind of withdrawing from those things and becoming very detached from your emotions. Sometimes people will talk about not really feeling close to their partner or children, not really feeling joy at things that happen with them, and difficulty experiencing positive emotions. The final two categories are one, changes in arousal and reactivity, and most commonly this is what we call hyperarousal, which is a fancy word that means anxiety. So although it has its own chapter in the DSM now, or there's a sort of trauma-related disorders chapter, I view PTSD as very much an anxiety disorder, and one of the core symptoms is chronic anxiety, and that's because they're having these repeated unwanted distressing thoughts of the trauma. So if you're living in a world where you can unpredictably have this highly distressing anxiety-provoking experience, you're going to develop chronic anxiety. What are some symptoms of chronic anxiety? Well, poor sleep. It can be hard to unwind at night and get to sleep. Poor concentration, because your brain's constantly kind of attending to this perceived threat. So it's hard to focus on other things. People get very irritable. They're kind of going around with a very full cup. Any kind of drop of water in that cup, and they can, kind of blow up and become angry and aggressive. People become very attentive to threat or hypervigilant to threat. And the best metaphor for this that I've heard is it's a bit like a sort of car alarm. those car alarms that go off when no one's trying to rob the car. That's kind of people with PTSD. They go up with their threat detector kind of turned up to 10, constantly scanning the environment for threat. You know, whenever they're out of the environment that they perceive as relatively safe, like their home, they're kind of on alert. And finally, the symptoms have to have been happening for at least a month. So if you're in that first month after the trauma, then the diagnosis, and you've got PTSD type symptoms, then the diagnosis that we use is acute stress disorder. That has similar but not quite identical criteria to PTSD, and we're not going to go through those criteria today. So complex PTSD is associated with complex trauma, which we talked about before, and adverse childhood experiences. It isn't included as a diagnosis in the current edition of the Diagnostic and Statistical Manual of Mental Disorders, but it has been included in ICD-11. The ICD-11 criteria include all of the usual PTSD symptoms that we've just talked about, the re-experiencing symptoms, the avoidance symptoms, the anxiety or hyperarousal symptoms, and in addition, 3 what are called disturbances in self-organization, and they include difficulties regulating mood and kind of emotional instability, negative self-concept, so kind of negative self-image, a poor sense of self, and then difficulties in relationships. And there's an overlap between the disorder, borderline personality disorder, and complex PTSD, and I talk a lot more about that in the complex PTSD video. So that should actually say how common is PTSD, not complex PTSD. Sorry about that. So some rough stats. So about 10% of people will experience PTSD at some point in their lives, and 5% of the general population will have PTSD, during the last year. So it's a really common disorder. It was the second most prevalent disorder on the most recent ABS mental health, epidemiological survey. And there are some populations that have a really high risk of PTSD and where you should actively kind of screen people for PTSD. And roughly the prevalence in all those populations is about a quarter. So, and those populations include female survivors of gender-based violence, military veterans, retired police officers, and survivors of natural disasters. So all of those groups have a risk of about 25%. So what puts someone at risk of developing PTSD? The standard way of categorizing PTSD risk factors is into pre-trauma risk factors, peri-trauma risk factors, and post-trauma risk factors. So the pre-trauma risk factors are all pretty unsurprising. So there are genetic factors that contribute to PTSD. It's got a heritability of something like 30 to 40%. Females are at high risk of PTSD, even when you control for trauma exposure, with the prevalence being roughly double in women. Having a younger age at the time of the trauma is associated with a higher risk of PTSD. Not being married, so if you're married, that's protective. Low IQ and educational attainment are risk factors, possibly because they affect people's ability to kind of process the trauma, make sense of it, as is low socioeconomic status. Having experienced past traumas and adverse experiences is a risk factor. Past history of other disorders and being higher in trait neuroticism is a risk factor. And then family history, which may relate to the contribution of genetic factors, at least partly. So let's talk about our peri-trauma risk factors. So I think the most important here is really the type of trauma. Potentially traumatic events that involve intentional interpersonal violence are more likely to lead to PTSD. The prevalence of PTSD in survivors of sexual assault is 40% at 12 months. And I did find a study that found that the lifetime prevalence in survivors of torture, refugee survivors of torture, was as high as 73%. There are sometimes methodological limitations of these studies, so we should take that with a bit of a grain of salt. But you can nonetheless see that there are some pretty high numbers there. We can compare those numbers with a prevalence of 22% for car accident survivors. The severity of someone's initial psychological response to a trauma is a risk factor. So if someone is very, very, very distressed after a PTE, they're more likely to develop PTSD. If they perceive that there was a threat to their life during the PTE, then that's a risk factor. And if they feel like they remain, at threat or in danger after the event or the apparent resolution of the event, they're more likely to develop PTSD. And there might be a contribution there of organizational factors. If you are part of an organization that really supports people well and helps them to feel safe after a traumatic event, then presumably that perception of threat diminishes. On the other hand, if there isn't an adequate organizational response and you continue to feel unsafe afterwards, your risk is increased. And there's also some evidence that if someone dissociates while the traumatic event is occurring, immediately afterwards, then they're at higher risk of PTSD. The post-trauma risk factors, we can summarize them by saying if something stressful is going on for you, including if you experience another trauma, then you're at higher risk of developing PTSD. And conversely, if you are supported, then you're at lower risk. So support is protective, and stress, is a risk factor. So what are some PTSD comorbidities? So comorbidity is extremely common. It's, as it says there, it's the rule, not the exception. Well over half of people with PTSD will also have depression. So if you're considering a diagnosis of PTSD, it's also worth taking a good depression history. Lots of them will have anxiety conditions, and you can see the prevalence is there. And finally, many of them will have substance use disorders, and you can see that nearly 40% of men with PTSD will have alcohol abuse. So that's a really important comorbidity to consider and screen for. And really, we can summarize that. What are the comorbidities? Depression, anxiety, and substance abuse. Those are the things that commonly co-occur with PTSD and that we need to be thinking about in someone who we think might have PTSD. So why is it so important to screen for PTSD? Well, firstly, as we've seen, it's really common in certain populations. So there are some populations who have a 25% chance of having it. So it's, important to identify it in those populations and help link those people in with treatment. A lot of people with PTSD won't tell you about either the trauma or their PTSD symptoms because of the avoidance that occurs in the disorder. So they hate thinking about their trauma. They hate talking about it. So they might not come into your clinic or your consulting rooms and say, hey, this traumatic thing happened and now I'm getting flashbacks. They might present with anxiety or anger problems or relationship problems or substance abuse. And you have to be the one that works out that actually this person's experienced a trauma and they're getting, nightmares and flashbacks and they're avoiding things. As we talked about, if PTSD, persists for longer than 6 months and it isn't treated, it can be a debilitating condition. And finally, there's quite a bit of evidence that it's very under-recognised and underdiagnosed. So there was one study that found that only 11% of patients in primary care had their PTSD diagnosis recorded in their medical records. So when should you suspect PTSD? So if someone comes in and tells you they've been exposed to a traumatic event, it's worth asking them about whether they're having any mental health difficulties relating to that event. If you've got a high risk population, if they're presenting with some of those comorbidities that we've talked about, and finally, if their partner or family, or another support person comes in and expresses concerns to you about their mental health, and you know that they've experienced a PTE, it's worth thinking about PTSD. That's a screening instrument that you can use in primary care. And this is the PCL5, which is a common self-report measure of PTSD symptoms. It's got 20 questions and a score of 33 or above is, kind of suggestive of PTSD. I actually think the PCL5 is a really good rough and ready way of working out whether someone has PTSD. We use it in our clinic. All patients coming into the clinic will fill out a PCL5, and most of the time, they've scored higher than 33, they will have PTSD. So how do we assess someone who, we think might have a trauma-related mental illness? I'm not going to go through all of this. Honestly, it's all pretty standard stuff. So as with any psychiatric assessment, you should cover all of the demographic factors. It's worth asking about whether they're working at the moment. For many people, the traumatic event will be related to their work, so they might be on work cover or sick leave. How much do you need to ask about the nature of the trauma? That will vary according to the clinical context and what your role is and what the aim of the the appointment is. If you are wanting to make a diagnosis of PTSD, or if that's an important aim to fulfill, then you will need at least enough detail to establish that they've experienced a PTE. Now that's often not a lot of detail, and sometimes what I'll say to patients is just I'm happy for you to give me as much or as little detail as you want. You can control and if they just haven't quite given you enough detail, establish that there was actual or threatened death, serious injury, or sexual violence, and you can prompt them a little bit and get those details. And if you can see that they're very distressed, it might be appropriate to, kind of defer further exploration of the nature of the trauma until another session, especially if you're going to be offering sort of longitudinal care to that person and you'll be seeing them the next week. You obviously want to ask about all those PTSD symptoms that we talked about. You want to ask about mood because depression is such a common comorbidity. You want to ask about alcohol and drug use because that's so common. As with everyone, you want to know about their past mental health history, their past medical history as well, for that matter. You want to know a little bit about their development, whether they were, experienced any adverse childhood experiences, the quality of the attachment to their parents, and you want to know about, who their important supports are now. And yeah, you want to know about, recent stressful events that might have contributed to their presentation and how they're functioning at the moment. And actually, that last one's really important. I always want to know is someone working? Are they able to leave their house? Are they socializing? Or are they? Many PTSD patients are confined to their homes. They'll do the shopping at 6 a.m. to avoid. If you ever hear that, think PTSD, because that's so common that someone will say, "Listen, I don't lightly leave my, I know I need to get groceries. I go there really early in the morning and I'm on a mission and I get it done." So and that all gives you a clue as to whether they have PTSD and how severe it is, and also can guide treatment. On an MSC, they might look anxious or agitated. They might look flat. There might be signs of poor self-care. You want to do a really thorough risk assessment in these people, including risk of self-harm and suicide, risk of harm to others, given that irritability and anger is one of the clinical features, risk of substance abuse we've talked about. People with PTSD can also engage in reckless, impulsive behaviour, so it's worth asking about that. And there are a whole host of medico-legal issues that are, kind of commonly arise as issues for PTSD patients, which I've mentioned some of those there. So how do we treat trauma-related mental illness? Well, we know that many people won't experience any difficulties. And we know that many people experience mild difficulties at self-resolve. So one of the key lessons of, PTSD research from the last, 4.5 decades is we don't jump into treatment too early. So if someone's come to you a few days after, a potentially traumatic event, don't diagnose them with PTSD and don't launch into delivering a PTSD treatment. Offer supportive care, encourage them to follow their usual coping strategies, monitor them, arrange some follow-up, see them again, monitor how they go. Many people will be okay. And in a stepped model of care, which is the current sort of paradigm, what you do is you kind of repeatedly assess people to see whether they develop difficulties. If they don't develop difficulties, great. They don't need any treatment. If they do develop difficulties, you can assess their severity and you can assess how long they persist for. And once they're hitting that 6-month mark, with significant disabling or very distressing difficulties, that's when you really, the people you really need to target for mental health intervention. I'm going to skip through a little bit of this. So, and you can see there that it's the usual pyramid where at the bottom you have, kind of universal interventions that everyone can do, like self-care and, seeking support from, support persons. And at the top of the pyramid, you've got the most unwell people who receive, the quaternary sort of specialist care. That's the paradigm we work with in trauma-related mental illness as well. Worth mentioning that routine psychological debriefing for trauma survivors, on a mass level is no longer recommended because there was some research evidence that suggested that it might actually increase the risk of developing PTSD, possibly by over-consolidating traumatic memories. So the recommendation now is for something called psychological first aid. It's pretty basic stuff. Monitor them, support the use of coping strategies that seem helpful, encourage them to follow their usual routines, not to use alcohol or drugs, and that kind of stuff. This is from a paper that looked at what do we do after a trauma? What's some intervention we can offer everyone, after a natural disaster, for instance. And basically the expert consensus was you want to do interventions that promote those 5 things, that promote hope, that promote a feeling of safety, that promote a feeling of community connectedness, and so forth. Level 2 interventions, I'm going to skip over because I don't think it's that relevant. So let's skip over to level 3 interventions. So these are interventions for people who have PTSD. So, they've had persisting significant difficulties that aren't self-resolving, flashbacks, nightmares, anxiety, avoidance, all of that. How do you treat PTSD? The most effective treatment for PTSD by far is something called trauma-focused psychotherapy. So it's actually a psychological treatment. That's one of my core messages for tonight. Medications in PTSD are really second line in there, or they're adjuncts. They're adjuncts to treatment, but the most effective treatment is talking therapy, and specifically trauma-focused talking therapy. And really, TFP is an umbrella term for a bunch of different psychotherapy modalities that have been demonstrated to work in PTSD. They include things like prolonged exposure, which is a very effective PTSD treatment that's got the largest evidence base supporting it. That's what I'm trained in. It's what I love using with patients. Cognitive processing therapy, which is all about helping them to challenge unhelpful thoughts related to the trauma or themselves or others or the world that are keeping them stuck. EMDR, which is the trauma psychotherapy where people reprocess the trauma while doing some form of bilateral stimulation like bilateral saccadic eye movements, and then trauma-focused cognitive therapy and trauma-focused CBT. So as I said, trauma-focused psychotherapy is very effective. All the clinical trials find large to very large treatment effects. Unfortunately, a huge number of patients with PTSD don't receive trauma-focused psychotherapy. One of the main barriers to accessing it is a lack of clinician training in that psychotherapy. I've got a video that will be released with this webinar that talks about trauma-focused psychotherapy. So if you want to learn more about those different modalities, watch that video. So briefly, let's talk about medications. So they can be used to treat PTSD and they can be helpful, but that usually they shouldn't be offered as first-line monotherapy. So your first step, once you diagnose someone with PTSD, shouldn't be to start them on a medication and then do nothing else. Your first step, the immediate priority, is finding a psychologist that can offer them those specific types of talking therapy that can help them to process the trauma and get better. But you can use medications. SSRIs and SNRIs, and specifically those agents there, have the best evidence base. They're first-line pharmacotherapy. Treatment effects are quite small. You can see a Cohen's d of 0.28 there. We often need high doses for PTSD, reflecting the fact that it's really, I think, an anxiety spectrum condition. If you try an SSRI in someone and they don't tolerate it, or it's not effective, and you've tried, try them on a reasonable dose, then I would, as a next step, switch to a different SSRI or SNRI. Once they're better, I'd recommend continuing their antidepressants for at least 12 months to minimize the risk of a relapse. There's a little bit of evidence also supporting atypical antipsychotics, including quetiapine and risperidone. If you take them at night time, it can help them to sleep. Poor sleep is a almost universal symptom for people with PTSD. So antipsychotics not a bad option, for a hypnotic that doesn't have a risk of tolerance or dependence. They're sometimes helpful for the anxiety or hyperarousal symptoms as well if you take them in the morning. Prazosin can be used to treat PTSD-related nightmares. I've got some interesting stuff about prazosin there, which you can read. There's a bunch of other medications, listed some of them there. These really have very little evidence supporting them in PTSD. We still sometimes use them because someone might be unwell and not have responded to other treatments, and you might be and they might, after you've discussed the option with them, be open to trialing it. But it's really important to talk to them about the limited evidence base for those options and also potential risks and side effects. Those are some scenarios where it'd be very reasonable to refer a patient to a psychiatrist. And I'll just finish with, my thoughts on prescribing for PTSD as a trauma psychiatrist. Take this with a grain of salt. This is N equals, however many patients I've seen. So I think SSRIs and SNRIs can be useful. They're certainly rarely a cure for PTSD. What they typically do is just kind of take the edge off the anxiety. So people talk about being sort of mellowed out a little bit, being a bit less reactive, maybe being able to leave the house a little bit more. I not uncommonly start people on an atypical antipsychotic to help their sleep. You can also use a sedating antidepressant like mirtazapine or amitriptyline for that purpose. If someone's on a high dose of an antidepressant and they've improved, but they're still getting a lot of daytime anxiety, I sometimes will use a mane dose of an antipsychotic. I think that can be helpful, for their anxiety as well. Although the evidence for prazosin is mixed and not super impressive. I think, it's reasonable to trial prazosin if someone's getting, recurrent, severe, distressing and disabling nightmares. And certainly I've met lots of patients who feel that prazosin has been very helpful for their nightmares. And I think when you are prescribing for PTSD, it's important to set realistic treatment expectations. So really the aim of medications in PTSD is to provide some symptomatic relief and improve quality of life while you're trying to link someone in with the trauma-focused psychotherapy that hopefully is going to be the definitive treatment for their difficulties. So I'll hand it back to Rahul now. I think we've got about 10 minutes for questions. Happy to talk about any, anything to do with trauma-related mental illness. So yeah, please shout out if you have any questions.
Thanks so much, Greg. Really great presentation. We do have a couple of questions. I've been doing my best to reply to some of them, and apologies for the slow typing on a few as we go. One question while I reformulate the other was around thoughts around complex PTSD, that overlay with depression and AOD and chronic suicidality in particular. I know we've got a dedicated video, recorded video will circulate on this topic, but I wondered if you wanted to comment at all around, the role of treatments in those in people who have that experience or around chronic suicidality.
Yeah, it's really an emerging space. So because complex PTSD was only included in the most recent edition of the ICD-11, as a diagnostic entity, it hasn't been around for a long time. And so there aren't a whole lot of clinical trials, where complex PTSD itself has been treated. As the condition targeted in those trials. There are a number of retrospective analyses of PTSD trials where they try to find subgroups who seem like they might have complex PTSD and look at the outcomes for them. I would say, and right now there are a whole bunch of complex PTSD clinical trials that are going on. I'd say as I talk about in the video, the evidence is actually promising. So the evidence suggests that trauma-focused therapy does work for complex PTSD. And there's some evidence suggesting that it not only helps all of those Axis 1 PTSD symptoms like the flashbacks and the nightmares and the avoidance, but it seems to also help, some of those other, the disturbances of self-organization. So difficulties in relationships, difficulties with self-concept, and mood instability. The other thing is that, many treatments for borderline personality disorder have been kind of, repurposed or get used with patients with complex PTSD because of the overlap in the features of those disorders. So, for instance, there's a treatment, DBTPE, which is a combination of dialectical behavior therapy and prolonged exposure. And that was designed for people with PTSD and comorbid borderline personality disorder. And is an evidence-based option for them, but probably will work well with people with complex PTSD as well. And it may be the DBT that's addressing, for instance, the emotional dysregulation and relationship problems.
Thanks, Greg. I'm about to type a response to the other, but we've also got a question around military personnel, the link between early treatment with morphine and lower rates of PTSD. My recollection with any of those, a lot of those haven't been well repeated, but
yes.
Curious.
It's a fascinating, the idea, can we prevent PTSD from emerging? So there are some populations we know are going to experience, trauma. So, frontline combat troops, we know that they are, probably at some point going to experience traumatic events. Police officers, we know in the course of their work, is there some intervention that can reduce the risk of them developing PTSD. I know there was a study on corticosteroids, that initially seemed to suggest that might be the case. I don't think there's been, any really robust evidence for a medication that reduces the risk of PTSD. In terms of morphine, so pain is a post-trauma risk factor for developing PTSD. So certainly optimizing pain management, probably will, after a traumatic event, will reduce someone's risk of developing PTSD. But yeah, I think it'd be wonderful if there were an agent that you could give someone after a traumatic event to stop them from developing PTSD. But there's nothing so far that's convincingly supported by the evidence.
Great. Well, we've got a pair, but I might start with Laurie Pierce's question around wildfire firefighters who are experiencing PTEs, yet still required to continue to respond. Any strategies that might be helpful kind of in the field after a long shift?
Oh, look, I don't know how first responders do their roles. I think they're incredibly demanding, and I think sometimes the general community don't realize how hard those roles are. I think there's not a lot of research on kind of optimal organizational processes for minimizing the risk of PTSD and trauma-related mental illness. It's an emerging. I would love to see large observational studies of fireys, police officers, looking at which groups are the ones that are at higher risk and what can you do to and when do you need to give someone a break. I don't know, Rahul. I have limited knowledge of firefighting on an operational level. Do you have any thoughts on sort of?
Yeah, look, I think, it is a very challenging space. I mean, a lot of the literature around and attempts around PTSD, the field really came about trying to kind of effectively get active servicemen, back into front lines and things. So there have been a lot of attempts and made around this, but I think in the end it is often around the basics remaining the basics, sleep, meals, connection, time off, all of those sorts of things are probably the most effective. And I think one of the big challenges, for us is that it's a lot of the informal activities, it's all the informal friendships, it's the informal kind of bits that are probably the most protective for those working on the front lines and in any particular field with high trauma exposure. And I think some of those things are probably underinvested in often or invested in, or need to be invested in kind of throughout someone's kind of journey within those professions rather than kind of at the pointy end when things are already kind of going a bit haywire. So it's certainly a wicked but interesting and important problem for us to kind of address as a society, I think. Now we have quite a few excellent questions, but very much running out of time. What I may do, I will drop my email into the chat. I'm happy for people to follow up following this. Let me just pop that in for any other kind of offline questions. But other than that, I think we might have to leave those for later and say my thanks to both this incredible audience and most of all to you, Greg, for walking us through this really interesting topic.
Thanks so much to everyone for dialing in on a Thursday night. Yeah, it's great.
Much appreciated. And yes, feel free to reach out, everyone, for some of those questions, and I'll try my best to email a response to them all. We very much appreciate it.